All right, everybody. Today is our technical assistance with People USA for the Youth Behavioral Health Community Crisis Centers. Before today's meeting, I was able to send out to each of you, I believe, a staffing composition document that People USA shared with me, as well as the supplemental materials they shared in the last TA. So you should have those. I won't take up any more time. I'm just going to pass it to Dave and Steve. If you have any questions, feel free to speak up and ask them. But we'll kind of just maybe start with going over that document, or let Dave and Steve take it away.
Yeah, great. Holly, is it possible for you to share the screen and put the staffing document up?
Yes, let me get it right now. All right.
So, and I guess just in terms of, if I would have known that, we were going to be recorded, I would have had hair and makeup come in, because, here I could.
Me too.
So what we thought maybe we could do today would be to go over the staffing patterns that we've used and why we use them. And then also, based on the information we sent to you last time following our meeting, just to see if you all had any questions on that material and as a start. So let's start with the staffing. So we have two types of centers that we have. And again, ours are both adult and youth centers. So that's the first thing. And in general, we plan for somewhere around 20 to 25 guests per day in these. And this is what that staffing pattern amounts to. And for us, an FTE is 2,080 hours a year. Just to, give you an idea of what an FTE is. Hopefully we're kind of standard with that everywhere. So and a number of the staff are the same when you look at the supportive and the intensive. So we've got a program director in both. That's a one full-time person, and generally that person is there on a during the Monday through Friday day shift kind of a person. On the supportive, we don't have a medical director. On the intensive, we do have a medical director. They're about 0.25. And then they're available by telehealth. So a day a week, they might be local on site in the facility, and the rest of the time they would be available by telehealth. And again, you can, I'm not going to, as much fun as it would be for you to hear me read each one of these, I'm not going to do that. Again, the key differences are, when you look at the psych nurse pracs, we don't have any of those in our supportive, but in the intensive we do. And again, we've got a day shift and a partial and then a partial shift through on the weekends is the way that works. We've got some on-call scheduling that we put in to take care of sick time, vacation time, that type of thing. And then we've got also on-call psychiatric nurse pracs as well that we use, and we do that virtually. So if again they cover areas or times when other people aren't around. So in total, it gives us somewhere, big round numbers, 25 to 27 staff members in terms of the types of staff that we have. One of the advantages that I think that we have that maybe you don't have is that because we have adults and adolescents in the same facility, different wings of that facility, though, or different parts of the facility, we can do some sharing, and that helps out with staffing, because when you and again at our 24 guests a day, it makes it, we're at an economy of scale there that we're not sure where you all are in terms of economies of scale on that, but that might be an issue for you all. Steve, anything you want to add to that before we open it up to questions? Oh, Steve, you're muted. You're muted, Steve.
Never find my mute button.
There you go.
Yeah. So what I'd like to add is, in the past 2 years, because of not vacancies but call outs and stuff, we did try to make sure that we covered that in the original budgets and the original staffing plans. What we found consistently is that we're about $200,000 short for overtime and coverage annually. And so this year we adjusted our budget to include additional Medicaid revenue, also additional deficit funding from state and government to cover that, so that we'll have a better balanced budget for this year. We don't anticipate that being an issue every year. Just with COVID, it's just been a challenge. And I think as we come out of this, it'll level out, and then the revenue will go back to not needing that amount of money. We might need some, but we won't need that high amount of $250,000 to cover annual costs.
So we'll pause at this point for questions, and there's a question in the chat. Scaling this down for our initial staffing might need to look like. So Charlene, how many guests are you looking at?
Yeah, so our and I need to like pull it up, and Cass might be able to correct, or any of you might be able to look. It's either 6 or 8 is the max. So our average might only be 3. So I think this is a beautiful staffing model that obviously works for serving 25 people a day.
Right.
But I don't think we're going to be there. And we want to make sure we're using like people to the top of their scope and the best of their ability, and et cetera, et cetera. So what might it look like for a minimum staffing model to serve very few people? And like what guidance are like what are the must-haves from your perspective, knowing that ours is going to be really different than yours?
Before we answer that question, how many of you are going to be, even though you're separate from the adult center, how many of you are going to have kind of co-located or near the adult center, so that there might be the possibility to share some staffing? Or is that not possible at all?
I think, and I'm sorry to speak up for Proactive, but I believe that they'll be leveraging an existing building that they offer other outpatient level services in. So they may be, but feel free to correct me, Proactive.
We're about 2 miles away from the adult crisis center. So in emergency type of situations, we could do some labor sharing, and then we provide some other services in the building that we're going to use the youth for. So our intent is to have some cost savings or sharing at least.
Okay. And is it also possible to use, what's the telehealth situation in and the allowability of telehealth for you all?
Yes, we definitely can use telehealth during the non-peak times. We plan on doing that.
Okay. And do you have some, sorry, Steve, to ask so many questions here. Do you have some staff that are at the adult centers that maybe are part-time staff, but they're looking for more full-time, and so they could be, a 50% time at the adult center and a 50% time at the youth center, that type of thing? Is there any way to make that kind of thing work as well?
That would probably be limited for us. We'll have a medical director that we're going to split between the two.
Right. Yeah.
So there will be some.
Okay. So I guess, what I would say is that I would definitely try on the medical director for these. I would definitely try and share that medical director. You're going to have one, but again, you don't need it at especially at the numbers you're talking about. That could maybe be virtual all the way. If again, that's we understand that all the everything hasn't been set up yet, but if you could do that virtual, that would probably be a better way to do that, because it'll be really hard to find a 0.25 psychiatrist to do that. So that would be something that we would suggest that you do. The the program director could also be one of your, could be your licensed person on that. And do that. Again, to the extent that you can use peers and have other people, to the extent that you can use peers as opposed to KSACs or peers as opposed to, some of the, some other types that would be important. The administrative assistant, medical biller, reception person, again, that can be somebody, one of the other staff can do that. You don't have to have that person be the, specifically there. Unfortunately, you're probably going to have a nurse, an RN, if it's an intensive. Steve, what am I missing?
No, that's right there. And we're talking about youth. I don't know that you would need a KSAC necessarily, but if you had a cross-trained peer SERPA, we have a staff that are cross-trained in those skills, would be helpful. But yeah, that's about it.
And again, because it's a 24/7 service, you've got to have, there's a minimum staffing level that you've got to have, right? So you've got to have, if you're going to have a peer, in order to cover that person, 24/7, it's not one person, it's 4.5, and then we used the on-call schedule to cover the other, but I think it's really kind of like 5.4 or 5.3 to make one FTE of somebody, and at those volumes, you're really only talking about one person, maybe two people. Does that make sense?
And Dave, I am not sure. I was just, as I'm looking at this and hearing the feedback you guys are providing, thank you so much. For the group's awareness, you all probably know that DJC and IDHW are doing a lot of work in the background to develop the standards that will help inform the staffing requirements and the developing the Medicaid reimbursable rate. But just by way of a little awareness for you all, IDHW DBH is developing those standards, and we had an extra TA with the folks from People USA we could share with them. So they met with the folks of DBH to kind of help share some of their insights and what they think might be helpful to be included in those use specific standards. So I don't know if you guys maybe have any insights of what you may have shared with IDHW in terms of staffing that might be helpful for this group to keep in mind.
Steve, you want to?
Yeah, we discussed the model in New York, the funding model, the Medicaid waiver information, some rating of funding in New York and things. So we just really started a preliminary discussion on what to look for and how to help fund the service without, to make it sustainable, basically. I mean, that's the point. So it was a lot of discussion around what we've learned in New York, what New York has created, and where they can go in Idaho to work with Medicaid to get this funded better.
Okay.
And they've asked us to actually, we're by the end of the week, we're getting a proposal to them to see, to help with that kind of thing in more depth and detail.
Thanks, guys. I'm hoping too that as that takes off, then that will help inform the TA and how we can help incorporate the standards DBH will be building into the technical assistance.
Yeah, I think one thing that they appreciated, and Dave brought it up while we were talking, is that there are different rates for people in length of stay, and it would really be helpful for you. It's going to be helpful for us. Is like a 3 hours and under was one rate, and 3 hours and over was another, and so they were intrigued by that, and I think that's a good plan to go forward with, so that you can have good flow, but in addition, you can get reimbursed, well, for the people that need more intense services when they come in.
Yeah. What was, I'm trying to think. I know there's something I wanted to share about the meeting that we had, again, for the grantees, DBH and IDJC and Medicaid and Optum, which for Steve and Dave, Optum's our managed care organization. We're meeting every other Friday just to start working through those milestones that I just mentioned, the billable rate and developing those youth specific standards. So one of the things that just, you know, keeping in mind, we're trying to keep in mind too, is as you all are, getting your facilities and obtaining locations and things like that. If you all have any contacts with Optum that you're close with, you know, you may just want to make sure that you're checking in with them to make sure that none of your building plans will run afoul with any CMS regulations or anything like that. So that's probably one of the only other insights I would share from that is just, you know, if you have any Optum contacts you can work with on that, it would be helpful to align there.
Good. Any other staffing questions?
So this is Ryan from Pathways. I had a quick question. So just when we look at, I guess just to talk about some of these part-time or virtual roles, right, of the psych MPs and the medical director. So at our current adult crisis center, the medical role we play for a client when they come in is really just that initial medical assessment, but we don't administer or distribute medications. We don't make recommendations related to medications. So if it's a requirement to have kind of a higher level here, it would be new territory for us. And I guess just a little insight, right, on, you know, we have a meeting next week to provide feedback related to the Idaho specific crisis center standards that are being developed. So I'll ask some of these same questions there. But you know, what is the role of the medical director? Is are the facilities we're talking about, do they play maybe a different role regarding medications and things like that than we will be playing?
Just to back it up a bit, is that when I first designed New York stabilization centers, I didn't have a medical role as far as having psychiatry or prescribing meds to people, because to me it was more important to create a system of care where the partners in the communities would fill those gaps, you know, the clinics, the FQHCs, you know, other services that are already prescribing and doing medication. The state is the one that came along and said, well, we want an intensive model that has more of that medication focus. We're building it now too, and I don't see the need for a lot of use, because again, in the other counties that we're designing and building, we're building those relationships at the same time to say, if we get someone to you and they're out of meds, we don't want to prescribe meds if they're already being seen by your clinic, or if they're new people, we want to be able to get them into your services rather than here's a handful of meds, good luck, because that's always been the downfall of the system of care. But we are going to be able to start at least a medicated medication assisted treatment, and again, as long as we have that strong partnership to get it out there. So I'm not a big fan of the med prescribing in the centers themselves, because again, you have very limited time with the guests that come in. And if you can build those relationships, do it. If it's an absolute emergency and somebody is in need of maybe a benzo just to calm down or something like that, I could see some usefulness in that, but it's so rare that we see that. But having it maybe in your tool belt might be something that, you know, could work for folks that really, you know, may need that.
Okay.
Real quick, sorry, Steve, just to you know, in your view, then, you know, that could be handled totally by virtual, not having somebody on site.
Absolutely, yeah.
And then another question I have is, I see, unless they're called something different, I don't really see like a case management or case manager allocation here. And, you know, in our facility, case management, you know, obviously folks come in and get assessed, and it's a place for them to be during their crisis. But that case management piece is, you know, probably one of the most important as far as getting them to the next best step in the community. I was just wondering how that was handled on this list here.
So we have case management there and available almost, I think 16 hours a day. They're brought in by another organization and that goes under their budget. However, what we're doing now in here in New York is we're including case management in our new budgets, and I should have put that in here actually. So yeah, it is a part of it going forward where there will be case management included in our own budget.
That's line 14 and 15 on the spreadsheet. The HH plus
Yeah.
care managers, health home plus care managers, and HR care managers. I forget what the R stands for. But that's where those line items would be. And again, we would, as Steve said, we would cover that 2 shifts during the day, or so 16 hours a day. So you'd be looking at something, again, for to do that, it's like 2.7 people to cover it for 2 shifts a day, 7 days a week. Bless you. But we also see that if you can do that internally and you've got that can also be a revenue source for you all as well. And we've been able to use that revenue to help make our models more financially sustainable.
Okay, that makes sense.
Anything else on
I
staff?
think one. Oh,
No, go ahead. Sorry.
I
Rod.
was just going to say. Oh, you're fine. I think one of the challenges, and kind of speaking to Charlene's question earlier too, is so there is this limited capacity, right, of 6, but it doesn't necessarily, it does to some extent, but it doesn't necessarily, based on the services we need to provide, limit the staff needs, right? We still have to kind of run on this firehouse model of when someone comes in, they need to be able to see someone for their clinical assessment, their medical assessment, and then have the case management and peer support services. So, I mean, the way we're kind of looking and budgeting right now is to kind of have 5 FTEs in each of those roles that accounts for that 24/7 coverage. We might, depending on what we discuss with DHW, there might be wiggle room with like the overnight needs, right? When obviously maybe a case manager is less important overnight when entities aren't open. And then obviously just the question of what is our goal around the medical care we provide. I think that'll really influence, the staff needs, and also funding, because that's probably the most expensive part of staffing this.
Yeah, and I think, like Steve said, for the medical piece, we tend not to, I mean, we rely more on peers and the, the LMSWs, and as opposed to, again, I think initially, Steve, and correct me if I'm wrong, we didn't even have registered nurses in the centers initially, or we had very limited use of registered nurses.
It was very limited, and then it went to heavily and it wasn't utilized, and then it went back to none, and so now it's coming back, and it's going to come back making more sense than what we're doing.
It does make it challenging if you're 3 to 6 people that you're serving, because you've got to have, there's certain staff you've got to have 24/7, no matter, if you've got one person, you've got 12 people or 15, you still got to have somebody 24/7. So that makes it, that's a challenge.
Yep.
Yeah. And that's where cross training, I think, comes in helpful. It's not always perfect, because you could have 6 people show up at once. And so now that's a logistical issue there. But if they're cross trained we have clinicians who are also peers, and sometimes that fills that gap, and case acts know what the peers do, and the nurses know what the social workers do, and so they can assist, and it helps to keep the center running and calm and people getting the needs met while they're there. Oh, so the standards for
Sorry,
staffing.
Cass, I just saw your question. Cass put a question in the chat. When does IDJC, IDHW anticipate completing the Idaho standards for staffing? So Val, feel free to correct me if I run afoul with my answer here. Good question, Cass. We are working on it right now. Trina and the policy unit at DBH are working on it. They're starting to explore. They're meeting with Steve and Dick to kind of figure out how they can incorporate some of the best practices from national into a local model that makes sense. It's a little complicated because what it takes to develop the standards and publish them according to Idaho's specific rules is a little more time consuming. So they don't anticipate having youth specific standards published by the close of the project period, but we're working on a workaround to be able to do that. So in order for Optum to develop the credentialing tool for you all to provide these services that would be Medicaid reimbursable, Optum needs DBH to develop the use specific standards, which would inform that credentialing tool. And DBH won't be able to develop those standards quick enough before the project period ends. So we are trying to get a little creative here. We are trying to leverage some of that supplemental money that we have been sharing with you guys that we have available, and maybe developing a basic set of standards that would be conveyed through the scope of work in subcontracts for that funding. Then Optum would just have a bare bones basic standards that they can then develop their provider credentialing tool on to credential you all into the network to provide Medicaid reimbursable services. And then as DBH expands and refines those standards, then the provider credential tool would be updated and those would be the new standards. But let me pause there. Val, does that sound right to you?
You said it exactly right.
Thank you.
Okay. So if there's, yeah, go ahead, Ryan.
I was just going to ask, with the development of those standards, is the goal to kind of have them pretty well aligned with the adult crisis center standards, just besides the consideration, obviously, for the youth care, but just with logistics and staffing and things like that, are you guys looking to align those pretty closely?
Yeah, and Val, I'll let you take the stab at it after. I just would say that was the goal. Trina Clark, who's the program manager of the policy unit, is really committed to developing standards that are achievable for you Idaho youth specific crisis center providers that also are reflective of national and local best practices. So she's going to be there. The team's really going to be trying to develop an amalgamation of all those things. So it shouldn't be something that would be completely different from what you're doing today or what they have for the adult standards. Val?
That's it. Yeah, basically that's it. I mean, we have the adult standards and we're starting with that template, and then we're going to elaborate for youth, the obvious pieces that are different than adults. And then we're looking at those national standards, all of those things.
Thanks, Val.
So I have a follow-up to that. As we're developing the RFP for the operating provider, what guidance would you have for us in terms of staffing for the RFP?
That is going to be a little more difficult. Will I post it to our group when we met the Medicaid DBH Optum folks that you guys are starting to develop these staffing plans, so you need a little bit of guidance or something. So let me think a little bit more about that, Cass, and staff it with Val a little bit more. And then we can maybe get back to you with a little bit better of an answer.
Okay, thank you so much.
You're welcome. And actually that is, I do DBH and Optum needed in, you guys are pursuing the subcontract for the youth crisis. Okay.
So one of the other things that we sent out, and you can stop sharing the screen now.
All right.
All right, thank you.
Now
Um,
bear with me.
One of the other things we sent out was one of the questions came about how do we handle things with the schools? Uh-oh. Oh, good. Okay. For a second, everybody froze. So we sent out our internal policies and procedures for how we deal with adolescents and the arrangements that we have with schools. So any questions on any of that material that we sent out? If you've had a chance to look at it.
I don't have any questions, but I really appreciate you sending that over. I found it to be really helpful.
Great.
Proactive, I don't think got that with the schools.
I believe I sent it out last week with the recording, but I'm happy to resend it out.
Yeah, if you could resend it, that would be great.
Absolutely. And this is just a slight aside, just as you know, you all are planning for those school arrangements and agreements. And Charlene will understand this, but you know, with assessment center projects, and there will be an assessment center in each of your areas where a crisis center will be, they'll also be having some of those relationships and formalized MOUs with schools for referrals. So it's probably would behoove each of the projects to really get in touch with the assessment center in your project, in your area, if you haven't already, so you can kind of understand what existing referral relationships may have already been forged with assessment centers. So those relationships that you're developing with schools and stuff can be complementary and perhaps, you know, have some shared resources with the assessment centers.
And then the other thing we sent out was the space plan and also the floor plans for our center that's being developed right now in Ulster County. And again, scale is different, and I understand the scale is different because we're looking at more people than you all were. But any questions about either of those two items that you got as well?
Quick question, Dave.
Yep.
I'm wondering, last TA, we were able to have Ryan kind of show their plans, and you guys were able to just give a little bit of feedback. I wonder if any of the other grant projects were, you know, if they wanted to share something like that with you guys to get some feedback, if that would be acceptable to you guys.
Absolutely.
Yeah.
Awesome. Thank you.
Yep, for sure.
What's the square footage on those plans that you sent?
I want to say it's about, isn't it up 8,000 square feet of space?
I think
Steve?
it was, yeah, I think it was between 75 and 8,000. Yeah.
Thank you.
I think the net square footage, before you gross it up with the quarters and stuff like that, is about 5,000 square feet of space, 4,500, 5,000 square feet of space.
I've got it open. It looks like the total area on maybe the second one or the last page is about 6,300 square feet.
So what happens when you try and do it from memory?
Hey, I mean, that's pretty good. Yes, Dave, I will send the adult standards for the adult centers that we have existing today after the phone. And I'm just going to, I don't want to keep anybody here. I know you all your time is valuable. So if you all don't have anything else for People USA today, we can give you back a little bit of time and we'll work on creating an agenda for the next time. Like they said, if you have any topics, please do email me, but we'll have a couple things in mind to chat about more for next time. And feel free to get in touch with me in the meantime. If you have floor plans you'd like Steve and Dave to take a look at, please let us know.
And
Any-
our next meeting is March 8th, by the way, just to, remind everybody that that's the kind of the cadence we're on. So sometime the, last week of February, we'll send out through Holly, just a reminder that, hey, the meeting's coming up, any specific topics you all want covered, or if you've got any specific questions that we can cover, that way we can have more specific information for you.
Awesome. Thank you, guys. And any lingering questions or any final thoughts, anyone? All right,
One last question. Sorry.
you're good.
Just one last quick question. Last time on the last meeting, there was some discussion around maybe the difference in security requirements at, the People USA facilities versus our current adult crisis center. Is there any just thought or consideration about changing that going forward, or for us to think about or plan around?
Great question, Ryan. So like I said, we're having those behind the scenes meetings with DVH, Medicaid, all that stuff. And so I did bring that up in the last meeting for Trina's team, that was some feedback we've received from the grantees, that if there's a way that they could maybe incorporate some flexibilities into those specific guidelines, it would be helpful. And she said that was really great input, and she's open to hearing more input related to the security specific requirements.
Okay. Thank you.
Yeah, you're welcome.
Yeah, and again, you saw in the staffing, we didn't have security in our staffing. And so we try not to do that.
Yeah, we have it, I think it's in the adult standards. And so I think as they're kind of re-examining those adult standards to develop the use specific one, there are some areas where they'll be maybe reconsidering, or just not reconsidering necessarily, but how do we align this the best with what's going on across the state and nationally.
Great.
Good.
All right, everybody. Well, I just want to thank Val and Steve and Dave for being here. Thank you all so much. If you have any questions in the meantime, I'm here for you. I'm your girl. Don't hesitate to reach out to me. And we'll see you all on March 8th.
Holly, do you want to stay after and talk for a sec?
Yeah,
Thank you,
absolutely.
everybody.
Thanks.
So everybody, appreciate your time today.
Bye,
Thank you,
everyone.
Bye.
Thank you.